So I'm just going to go through metabolism here, talking more specifically about thyroid disease and also parathyroid disease. So concept definition. So metabolism refers to the sum of all physical and chemical processes by which living organisms are produced and maintained. So basically, there are biochemical reactions that occur in the body cells to produce energy. They also help to repair cells and maintain life. So the anterior and posterior pituitary kind of get signals from the hypothalamus that tell the whether it be anterior or posterior pituitary to release certain hormones that act on other endocrine glands in the body. Of the concept, so you can have underactive metabolism. So in this exemplar, it's going to be your hypothyroidism. We'll talk a little bit more about that shortly. Then you'll have normal metabolism, or like euthyroid, meaning that your thyroid levels are stable, they're well balanced. And then you can have overactive metabolism. In this case, it's hyperthyroidism. So what are our risk factors? So genetics. People can have congenital defects in their endocrine glands, especially too with like family history, for instance, of like diabetes and things like that may put someone at risk for developing diabetes themselves. Diabetes is also another exemplar of metabolism. So anything that can basically affect your metabolism will put you at risk for an alteration in metabolism. So your age. So as you age, your metabolism tends to slow down. When you're younger, your metabolism's a little bit faster. Certain hormones, again, we'll talk more about that with the exemplar. Your body temperature. So body temperature is going to accelerate metabolism. Everything's going to sort of be heightened when your body temperature is elevated. If your body temperature is lower, everything tends to slow down. You have a lower, slower metabolism. Something that comes to mind with that is when we take care of patients in the ICU who are undergoing hypothermic protocol, or in other words, keeping their body cold after they've sustained a cardiac arrest, you definitely notice a change in all of their vital signs, like their heart rate begins to slow down, and all of their processes in their body you can just see have sort of been suppressed. So lower body temperatures are going to kind of slow everything down. And then you think of your patients with fevers when they are, spiking temperatures, their temperature is rising. What do we tend to notice? We see their heart rate starts to go faster. So that is sort of a sign that their metabolism is picking up. When you have a faster metabolism, your vital signs, your heart rate tend to be a little bit more elevated. Exercise. So people who exercise tend to have a faster metabolism. Sleep, your metabolism slows down. Nutritional status, if you're malnourished, can also play a role and cause a slower metabolism if you're malnourished. Decreased liver function. So think of in alcohol abuse, when your liver eventually over time develops all that fibrosis and scarring and ends up developing whether it be hepatitis C or cirrhosis, and then your liver is unable to function normally anymore. So it's unable to metabolize certain medications, certain substances, because the liver function is abnormal. Inadequate perfusion of oxygenated blood. So again, in cardiac disease or pulmonary disease, think of when there is an alteration in the perfusion, you start to see the changes on multiple body systems. Thyroid disease. So the endocrine system plays a vital role in orchestrating cellular interactions, metabolism, growth, and senescence. So it's closely linked with the nervous and immune system, and also regulates functions of many organ systems. So in talking more about the thyroid, it is a butterfly, or sometimes people call it saddle-shaped gland that wraps around the anterior portion of the trachea, just below the larynx. So the thyroid excretes 3 hormones, and those are your T3, your T4, and also something called calcitonin, which we'll talk about in a moment. But all of these hormones, which are classified as just thyroid hormone, have some sort of effect on all major organ systems. So again, back to what is stated in the PowerPoint, it regulates the functions of many organ systems. So that has an effect on an individual's metabolism, on their cardiovascular status, on their GI system, neuromuscular system. Okay. Thyroid disease is one of the more common endocrine disorders. And if it's left untreated, it can actually be very harmful to the body. It can lead to cardiac disease and potentially even death if it is untreated. for thyroid disease. So serum TSH is what we monitor to see whether or not someone may be hypothyroid or hyperthyroid. And as you can see here, the American Thyroid Association recommends screening begins at 35 years of age and every 5 years thereafter. All right, so the serum TSH is sort of what we look at for recognizing thyroid dysfunction. So TSH is going to be low if someone is hyperthyroid, and it's going to be high if someone is hypothyroid. All right, so then we can monitor things like their free T4, their total T3, total T4. Okay, it's not necessary that you know all of these, but it is important to know your TSH levels. Okay. Other tests that can be used for thyroid disease is T3 resin uptake. So there are tests that can be done that patients will take a dose of radioactive iodine, and they can monitor to see how much of that iodine has been sort of absorbed, if you will, to the thyroid and sort of sticking on the T3 cells, hormone cells. Thyroid antibodies can also be used, especially when looking at autoimmune diseases of the thyroid. For instance, like Hashimoto's disease, that's an autoimmune disease of the thyroid. People who have elevated thyroid antibodies likely have an autoimmune thyroid issue. Evaluators. So the radioactive iodine uptake, so I kind of just talked a little bit about that, measures the iodine uptake by the thyroid. So someone is given radioactive iodine, okay, so like by pill form, and then they can sort of scan the thyroid with a special machine to see how much of that iodine was sort of absorbed or taken up by the thyroid. Your fine needle biopsy. This would be used when someone has nodules on their thyroid gland that they want to look to see if they have malignancy or not. Thyroid scan, radio scan, or a CT scan determines anatomical characteristics and the functional status of the thyroid. So this here is like your CT scan where you can see all these different colors. This little red spot noted on the lobe here is what they call like a hot spot. So that's sort of like an area that is hyperactive per se. Implications. So when patients are undergoing diagnostic testing for thyroid disease, especially if it includes radioactive iodine, you want to be aware if these patients have allergies to shellfish or iodine. Certain medications will also alter sort of the results of tests because some medications contain iodine. So for instance, amiodarone contains iodine. So when patients are taking amiodarone, we have to sort of monitor their thyroid levels to be sure that their T4 level's not going to elevate. And same thing with aspirin. That causes an increase in their thyroid hormones. So if someone already has high levels of thyroid hormone, for instance in hyperthyroidism, then we may be educating them to avoid things like aspirin. Other medications such as lithium or dilantin, those can have an effect that end up decreasing someone's thyroid levels or T4 levels. And same thing with propranolol. So I don't expect you to know all the details of these medications, but some of the bigger medications that we tend to see more often, I would expect you to be familiar that they can alter someone's thyroid function and can also alter their, diagnostic testing. Because if you're giving somebody iodine as part of their diagnostic testing, like radioactive iodine or something, and they also have been taking medications that contain iodine, that could be actually larger amounts of iodine than they think they are receiving for their diagnostic studies. Okay, so some of the ones that we see more often are the ones I just mentioned, like your amiodarone and your aspirin. Those can both increase your thyroid hormones, and some others like lithium, dilantin, propranolol. Those can actually cause a decrease. Thyroidism. So sometimes it's also called myxedema, okay? And it is called myxedema because there tends to be a development of non-pitting edema in the connective tissues throughout the body. So in hypothyroidism, there are suboptimal levels of thyroid hormone, or in other words, low levels of thyroid hormone. So it does occur more frequently in older women, but can also be diagnosed somewhere in your middle age as well. For instance, like 30 to 60 years old. So some causes of hypothyroidism can be things like the Hashimoto's thyroiditis that I talked about a little while ago. So Hashimoto's is your autoimmune disease, okay, of the thyroid. Also, post-Graves' disease, which means that at one point this patient actually was hyperthyroidism, because Graves' disease is a cause of hyperthyroidism. But sometimes over time with hyperthyroidism, your thyroid kind of burns out, okay? Or the functioning over time starts to slow down, especially if you're receiving treatment for it. So the reason it says post-Graves' disease is because someone had Graves' disease, which means hyperthyroidism, over time, whether it was because of treatment or the thyroid sort of burnt out over time, they have now developed hypothyroidism. Okay, if that makes sense. I know it sounds a little confusing, but basically think of it as like, all the treatments for hyperthyroidism and Graves' disease eventually causes the thyroid to slow down and not function as fast or as normally anymore, which ends up resulting in a slower or lower thyroid hormone production. Okay? Atrophy of the gland can occur with aging. Therapy for hyperthyroidism I just talked about, for instance with the Graves' disease. Certain medications, so I talked about some medications that cause a decrease in thyroid hormone, right? So that's like your lithium, your dilantin, propranolol. Radiation to the head and neck can also cause hypothyroidism because it affects all of the cells in the neck, and the gland for the thyroid sits right there anterior to the trachea. So those cells can also be affected, possibly even become, scarred over time, and then they're not going to function normally anymore. Infiltrative diseases of the thyroid. So again, that's sort of like where your thyroid develops scar tissue per se, and the cells are unable to function normally. And then iodine deficiency is also a cause. Okay, iodine deficiency, we really don't see that often in the United States, but there are some developing countries that may not have iodine in their environment. In the United States, we typically have a sufficient amount in our soil, so we are taking in iodine with our regular everyday nutrition. But it's for in different areas of the world where their iodine may not be as adequate in their soil and in their nutrition, that people end up with an iodine deficiency. Iodine excess can also lead to hypothyroidism. And again, that goes along with therapy for hyperthyroidism. Okay? So, clinical manifestations. So, they will be extremely fatigued, brittle hair and nails, very dry hair. They may have a hoarse voice. Their hair may fall out, which is alopecia. Sensitivity to cold. Okay, those are kind of your common signs and symptoms. So again, think of it as your metabolism is slow. Okay, everything is kind of slowing down. So these clinical manifestations in hypothyroidism can develop over months to years for people. Another common clinical manifestation too is a large goiter, which a goiter simply means that the thyroid gland has become enlarged. And the reason it becomes enlarged is because the thyroid has been overcompensating for the low amounts of thyroid hormone. Okay, it's becoming to try to work harder and harder to make more hormones, and it ends up enlarging itself. Okay. So there is a picture of these clinical manifestations. I believe it is on the next page. But hypothyroidism, I'll give you sort of a little way to think of it, hopefully make it easier to remember and differentiate hypo from hyper, is actually a personal story from myself. So I had recognized after having my son, actually began during pregnancy, that I was developing things like a hoarse voice. I was extremely fatigued. My hair was actually, starting to fall out. It was very dry. And once I had my son, they took me off the medications for hypothyroidism. I was on levothyroxine just for the end portion of my pregnancy. And they said, okay, this can happen during pregnancies. It's kind of like your thyroid trying to overcompensate and for the pregnancy and all the demands on your body, etc. So they took me off the medicine. But then a few months after I had my son, I started noticing all the same symptoms. And it took me a little while to piece them together. But literally, I was so surprised once I thought of it and was saying to myself, oh my gosh, could this be my thyroid? And so I went to my doctors and ended up having them check my TSH level, and my TSH level was 13. Okay, so remember the normal is less than 5 for a TSH level. So with that, they, recognized that clearly it did not resolve after my pregnancy, and I now have hypothyroidism. And I had all the exact classic symptoms that are listed here in the clinical manifestations. And some of these things still do apply, even with taking my medication, every day now for, almost 2 years. Definitely have more fatigue. I am extremely sensitive to colds, and multiple signs and symptoms of hypothyroidism are still sort of present even with the treatment with levothyroxine. So try to think hypothyroidism, oh, okay, hopefully it clicks in your mind. That's, what Kim has, and this is what she has, to sort of differentiate. Hopefully it will help you going forward when you're trying to think the difference between hypo and hyper. All right, so if hypothyroidism is untreated and it becomes more severe, then patients are going to start having lower body temperatures. They'll have bradycardia. Remember, everything is slowing down with hypothyroidism. They end up having weight gain, thickened skin, irritable personality changes, okay? May also have some memory impairment. And if this goes on without treatment for a long period of time, it can actually lead to elevated cholesterol and triglyceride levels, which would then put the patient at risk for atherosclerosis and also some cardiac disease. So there is a life-threatening complication of hypothyroidism, and that's called myxedema coma. So myxedema coma is life-threatening. Again, highlight that, underline it, whatever you do. And it is caused by long-standing untreated hypothyroidism. So sometimes there can be a trigger that sort of starts this snowball effect into myxedema coma. And that could be like an illness or a trauma or sustained exposure to cold. So it is more common to happen in winters. But basically, patients present with hypothermia. They have metabolic derangement, meaning their electrolytes become unstable. So they may be hyponatremic, hypoglycemic, okay? Their heart rate, as I said, begins to slow down, okay? They may end up with cardiovascular collapse, meaning that their, heart is unable to keep up and sustain an adequate cardiac output. They have a change in mental status, impaired mentation. They may be more lethargic. And if this is untreated, it will lead to coma and potentially death. So the treatment for myxedema coma would be addressing whatever is the cause of this myxedema coma. You also want to ensure that the patient has a patent airway, that they have adequate cardiac output, meaning, adequate heart rate, adequate blood pressure, good perfusion, all right? Monitoring their electrolyte status, okay? You want to increase their body temperature because, again, their body temperature is going to be subnormal or low. So they may be on like a warming blanket. And also, you want to administer thyroid hormone, okay? So if patients are unable to take an oral dose of thyroid hormone, like levothyroxine, it can be given IV. So they can get IV levothyroxine, okay? And they can also get IV T3 as well, okay? So if it's untreated, the mortality rate is very high, so that's why it's important to promptly recognize any clinical manifestations of myxedema coma. And it is pretty rare, but it can happen in instances where someone really isn't treating themselves adequately for hypothyroidism, or if they are exposed to, a traumatic event or illness and exposure to long time exposure to cold temperatures. All right. Here of hypothyroidism. So you can see intolerance to cold. All right. So this is pretty much, me every day, bundled up as much as I can, multiple layers. Receding hairline. They also may have some facial and eyelid edema because remember, hypothyroid, the other name for it is myxedema. And that simply means that there is non-pitting edema of the connective tissues in the body, and that also includes in the periorbital space behind the eyes. They may have a dull, blank, flat expression, extreme fatigue, may have slowed speech and a thick tongue. That's more so in cases of severe hypothyroidism. Anorexia, the brittle nails and hair. They may have menstrual disturbances, hair loss, apathy, lethargy, dry skin, muscle aches and weakness, constipation. So the late clinical manifestations are what I mentioned on the previous page. So their body temperature begins to lower. It's subnormal. They may become bradycardic. They end up with weight gain, have decreased level of consciousness, thickened skin, and eventually cardiac complications. So remember, I did mention that it can increase your cholesterol and triglyceride levels, resulting in a risk for atherosclerosis and cardiac disease. I accidentally hit the next button, so I don't know if this just erased my recording for this slide. I'm just going to go through it again, just in case it did. So treatment for hypothyroidism would be your levothyroxine. So you've heard me mention that a little bit throughout this lecture so far. So levothyroxine is your thyroid hormone replacement. So it's also called Synthroid, Levothyroid sometimes. All right, so important facts about levothyroxine is that it should be taken on an empty stomach. So pretty much the common recommendation is to take it first thing in the morning when you wake up with a full glass of water. So the reason we say a full glass of water is because if you take this medication with just a little sip of water, or some people take it, since it's such a tiny pill, they may take it without any water, that can be bad for your esophagus and end up leading to esophageal problems. So we do recommend with patient education and teaching that they take it in the morning on an empty stomach at least 30 minutes before their breakfast with a full glass of water. Another reason that we do recommend morning is because sometimes when it is taken in the evening, it can lead to a little bit of insomnia. So it is recommended, general guidelines, for the morning, first thing, empty stomach, 30 minutes before your breakfast with a full glass of water. And that's exactly what I do. I keep my levothyroxine right on my nightstand. I wake up, take my morning pill, and then I know there's at least going to be 30 minutes before I am eating breakfast. So that's an important thing to educate clients about. Also important is the signs and symptoms of overdose, okay? So if you are taking levothyroxine, that is a synthetic form of your thyroid hormone. So if you're taking too much of it and your thyroid hormones are elevating, then what are you going to see? You're going to see signs and symptoms of hyperthyroidism. So that's your palpitations, insomnia, increased appetite, tremors. So you always want to educate your clients of what the sort of overdose symptoms sound like or appear to be like. And that is your hyperthyroid symptoms. Okay, because that just means that you have too much thyroid hormone circulating in your body. So with elderly clients, it's also important to understand that they may not clear the medication, through their kidneys as well as someone who is younger. So they may be at higher risk for developing signs and symptoms of thyroid hormone overdose. So it's important with elderly clients to sort of start them with a lower dose and increase them in smaller increments to be sure that they're going to be able to tolerate it and not develop hyperthyroid symptoms. Okay? So they are at risk for altered metabolism and also altered excretion of medication that I just mentioned, like in elderly clients with renal clearance problems. So being aware of that as a nurse caring for these patients and also educating the patients is important. Okay? So levothyroxine is the primary treatment for hypothyroidism. Okay, sometimes if patients have a really big enlarged thyroid, the goiter, like I mentioned previously, They may have to have some surgery on their thyroid to reduce the size, especially if it's compromising their airway at all or their swallowing. So they may end up having something called a subtotal thyroidectomy, which means that they remove part of the thyroid to decrease its size. But the primary treatment is the thyroid hormone replacement, levothyroxine. So nursing care for these patients. So you want to provide a warm environment. Remember, intolerant to cold. So you want them to stay warm, because if they're cold, they could, end up shivering, which then increases their metabolic rate even more and puts more stress on their heart. Their diet is oftentimes recommended to be high protein, low calorie, small frequent meals, and also including increased fiber intake and fluid intake, because remember, a clinical manifestation of hypothyroid is constipation. So, with fluid intake, increasing it could be like 2 liters a day. Fiber intake, could be things like increase like your daily intake of potatoes and, whole wheat and all that stuff for increased fiber. Okay. Administer sedatives with caution. So central nervous system depressants or sedatives can precipitate myxedema coma. Okay, so think of how your metabolism is already slow with hypothyroidism. So if you give something like a central nervous system depressant, which is going to slow the body down even more, everything's going to sort of become too slow and put them at risk for myxedema coma, which results in cardiovascular collapse, poor cardiac output, poor perfusion. So sedatives should really try to be avoided in patients with hypothyroidism if possible. Frequent rest periods and pace activities. So this again has to do just with the stress that it puts on your cardiac output and your heart. So allowing time to rest and not distress your cardiovascular status at all. Daily weights are important as well because patients with hypothyroidism are at risk for increased weight or weight gain. Monitoring for signs and symptoms of levothyroxine overdose. Okay, that's your signs and symptoms of hyperthyroidism. And educate about causes of myxedema coma. So I mentioned earlier that can be like trauma that happens to them, infection, exposure to cold temperatures for long periods of time. The sedatives or central nervous system depressants can also put people at risk. And also if they're just not treated for hypothyroidism, right? If they just decide, well, I don't want to take my thyroid medication anymore, then they're going to put themselves at risk for myxedema coma. Okay, some other things might be, skin care, like turning repositioning if they're in the hospital, using warm water as opposed to hot water, because that would just sort of lead to more drying of the skin and put them at risk for skin breakdown. So some of the simple things like that can also apply to patients with hypothyroidism. And then we have the opposite here, hyperthyroidism. So this is an excessive synthesis and secretion of thyroid hormones, okay? So that's your T3, T4 are going to be high, and your TSH is going to be low. So again, this is more common in women, okay? It does affect all major organ systems, all right? Because remember, the thyroid hormones have a direct effect on basically every organ in the body. And with hyperthyroidism, the metabolic rate is elevated. Okay, so these patients tend to have a higher heart rate, higher stroke volume, which means they have a higher cardiac output, Okay. They may also, over time, end up with some nutritional deficiencies and calorie deficiencies as well, just because of the rate that their body is metabolizing all the components of their nutrients, such as like carbohydrates, proteins, things like that. Causes of hypothyroidism is Graves' disease. Okay, so that is an autoimmune stimulation. I mentioned that. And hypothyroid, because remember, Graves' disease and treatment over time may lead to hypothyroidism. All right, but basically with Graves' disease, the antibody attaches to the thyroid stimulating hormone, or TSH receptors, and that stimulates the secretion of more thyroid hormones. Okay. They may also have causes such as toxic multinodular goiter, which simply means that there are multiple nodules on the thyroid that may be cancerous, like a neoplasm, causing excessive secretion of thyroid hormone. Toxic adenoma, same thing, thyroiditis. So again, hand in hand with higher levels of antibodies, thyroid antibodies. Excessive ingestion of thyroid hormone. So that's your levothyroxine. So that would be someone who's being treated for hypothyroidism. If they're taking too much of their levothyroxine, they can end up with hyperthyroidism. And also severe stress can lead to hyperthyroidism as well. So clinical manifestations. So patients with hyperthyroidism, think of it as everything is heightened, everything is increased. Okay, so they're oftentimes more jittery, nervous, emotionally hyperexcitable. Okay, they may be having intolerance to heat. Also have exophthalmos, which means that their eyes are sort of bulging forward, and that's due just to inflammation, behind the eyes that end up pushing it forward. These clients can also have a goiter, which simply means that it's an enlarged thyroid gland. They tend to be more tachycardic, high blood pressure. So remember, just a short while ago, I mentioned they have a higher cardiac output, so that would mean higher blood pressure. Weight loss, facial flushing, sleep deprivation or insomnia, diarrhea, and frequent mood swings. Older clients can also present with episodes of like a new atrial fibrillation, or maybe an acute CHF that they haven't had before, and it could be related to an undiagnosed hyperthyroidism. For visual people, so intolerance to heat, fine straight hair, the bulging eyes or exophthalmos, facial flushing, a goiter, enlarged thyroid, tachycardia, high blood pressure, breast enlargement, weight loss, muscle wasting. They may end up with clubbing of the fingers, tremors, diarrhea, also menstrual changes, and localized edema. So some complications of hyperthyroidism. So thyroid storm. Okay, this is something that also is life-threatening. So this is just a very severe form of hyperthyroidism, and it can be caused by untreated hyperthyroidism, hyperthyroid patients who are exposed to some big stress, such as an infection, trauma, diabetic ketoacidosis can also put patients at risk for thyroid storm. But this is a rare, complication that can happen. It doesn't really happen as much these days because patients are more closely monitored and treated with hyperthyroidism. But it is important to know that it is a possibility for complication, and it is life-threatening. So your clinical manifestations. So think of hyperthyroidism. Everything is accelerated, everything is heightened, so your metabolic rate is increased because of the increased thyroid hormone secretion. So they're going to have high fevers. So they can even go up to like a fever of 106. They're going to be tachycardic, as you can see here, greater than 130. Hypertension, exaggerated symptoms of hyperthyroidism. They may have abdominal pain, nausea, vomiting, diarrhea. They may also have altered mental status like agitation, confusion, possibly even delirium, and also end up with seizures as well. So this does have a high mortality rate, and treatment would include reducing the body temperature. So you would want to do this by like a cooling blanket. If possible, you don't want to induce shivering at all, because remember, what does shivering do to the body? It increases its metabolic demands, and someone who's already hyperthyroid, you don't want to increase their metabolic demand anymore. So you want to try to cool them down like slowly with cooling blanket without inducing shivering if possible. Remember, you don't want to give aspirin to patients with hyperthyroidism because aspirin increases the thyroid hormone, okay? So you would avoid aspirin. Reduce heart rate, so that would be things like propranolol, like your beta blockers that you could use. Enhance oxygenation, ensuring that they have a patent airway. Also monitoring their vital signs like cardiovascular function, their cardiac output, that they're perfusing well, and administer anti-thyroid medications. Okay, so we'll talk about those medications shortly. Pharmacological. So they do have radioactive iodine therapy. Okay, so this would be like a pill that they take that is containing radioactive iodine, and in high doses, the iodine will damage the thyroid cells. So if they damage the thyroid cells, they're going to produce less thyroid hormone. Okay, so a lot of the times with radioactive iodine, you don't necessarily need radiation precautions, but it is important to educate clients who are taking radioactive iodine that they may become hypothyroid from it, because think of what the iodine is doing. It is damaging the thyroid cells, and they produce less thyroid hormone. So if they're producing less thyroid hormone, then that could lead to hypothyroidism. Okay, so educating about signs and symptoms of hypothyroidism. And that pretty much goes along for any anti-thyroid medication, that it can result in hypothyroidism. Okay, some other medications are the propylthiouracil or PTU and methimazole, tapazole. Okay, so these medications also inhibit the incorporation of iodine atoms into T3 and T4, so therefore reducing the amount of, secretion of T3 and T4. So with these medications, they're pretty potent. The tapazole is a little bit more potent than the PTU, but it's important to monitor these patients for signs and symptoms of like immune dysfunction, so leukopenia, also things like agranulocytosis. All right, it can also be toxic to the liver, and tapazole is a medication that cannot be used in pregnancy. So if you have someone who is hyperthyroid during pregnancy, the PTU is oftentimes what they're going to choose. So the iodine solutions like sodium iodine, potassium iodine, specifically here saturated solution of potassium iodine, can be used to suppress the thyroid function prior to surgery on the thyroid, so like a thyroidectomy or something. Potassium iodide, like something called ThyroBlock, which isn't listed here, it can be used to decrease the vasculature in the thyroid, because the thyroid is so vascular. It actually has like 5 times the blood flow than the liver does. It's very, very vascular. So when patients are going to undergo like a surgery for their thyroid, whether it be a subtotal thyroidectomy or a total thyroidectomy, they're at high risk for bleeding and hemorrhage. So sometimes these iodine solutions are given to suppress the vascularity in the thyroid gland. This type of iodine is non-radioactive, okay, and it's most likely given before surgery. Sometimes they may need like a steroid just because of the heightened metabolism, the stress on the body, and they may sort of need like a stress dose of dexamethasone or steroid while their body is sort of in that heightened state, and especially if their body is in like a thyroid storm type state. And then the beta blockers like propranolol I mentioned with thyroid storm, it's important to sort of keep their vital signs under control. So thyroid storm, they're going to be more tachycardic, hypertensive, etc. So propranolol can help to bring your vital signs down. And also remember what propranolol does too. From the beginning of the lecture, it helps to decrease your T4 levels. And then surgical treatment would be your thyroidectomy. So that can be subtotal, meaning partial thyroidectomy, or a total thyroidectomy. All right, so I believe I do have a slide in here next that talks a little bit about the nursing care for thyroidectomy. So I'll discuss that in a moment. But overall, nursing care for hyperthyroidism is, sort of providing a less stimulating environment. So remember, their bodies are already heightened, their metabolism's fast, their basal metabolic rate is heightened and elevated, so you want to just let them rest. Activities that are quiet, such as reading. I already mentioned provide rest periods, maintain cool room temperatures because they have intolerance to heat. Same thing with light clothing. You don't want them to have heavy clothing or something that's going to raise their body temperature too much. Stimulants such as coffee should try to be avoided simply because of the effect on their metabolic rate. It's just going to increase it even further. And when caring for these patients, just trying to consider utilizing a calm, sort of unhurried manner when caring for them. Again, having to do with their sort of hyper-excitability, their nervousness, their jittery. So you kind of just want to keep everything calm for them, okay? So when caring for patients who are undergoing a thyroidectomy, whether it be subtotal or total, it's important to reduce their stress and anxiety beforehand, because think of what stress can do to the body when someone is hyperthyroid. The stress can precipitate a thyroid storm. Avoid caffeinated beverages and other stimulants. Same thing as I just discussed on the previous page, because the metabolic rate is already increased. Explain all their tests and procedures, and explanation of their head and neck support after surgery. So, when patients have thyroidectomies, it's important to keep their head sort of in a neutral position. You don't want to hyperextend the neck or, have the head go back, because that can pull on the suture line, because your thyroid is anterior neck, right? So you're going to have sutures in the front. So, all right, so head and neck is to maintain, sort of neutral, so they don't hyperextend and pull on their suture line of their anterior sutures. So for post-op care for these patients, monitoring airway is important. Maintaining a tracheostomy at the bedside is also important, because if they develop some swelling around the insertion site or incision site, I should say, then they may block off their airway. So that would be an emergency, and they would need an emergent tracheostomy placement. Also monitoring for bleeding. Remember, the thyroid is very vascular. So if someone is having surgery on their thyroid, maybe subtotal thyroidectomy, just removing part of it, we want to be sure that they are not bleeding excessively. Also pain management, positioning in semi-Fowlers. You want to also assess the patient's voice, again, because of where the location of the thyroid gland is. It is anterior to the trachea, just below the larynx. So during surgery, the larynx could possibly be harmed by accident. So you want to be sure that they are able to talk, but you don't want them talking too much because that could put too much stress on that area. And then also monitoring their calcium levels. So the reasoning behind this is because the thyroid has 4 other glands sort of embedded within it. And these are called your parathyroid gland, okay? So your parathyroid glands secrete hormone called parathyroid hormone. And parathyroid hormone helps to regulate the calcium levels in your blood. All right, so if someone has a thyroidectomy, those parathyroid glands could potentially be removed as well, or they could be, sort of harmed in the meantime and cause a disruption in their ability to secrete the parathyroid hormone. So if the parathyroid glands are, harmed or altered, then they're not going to be able to sort of secrete the parathyroid hormone, which would help to keep the calcium levels balanced in the body. So they end up with hypocalcemia and tetany, okay? So people who have had a thyroidectomy should be monitored for low calcium levels and also for tetany. And tetany can be described as just like tonic muscle spasms, all right? And some other signs and symptoms of low calcium levels are like Trousseau sign, Chvostek's sign, that I can never say. And we'll discuss those in a little bit with the parathyroid slide. But if patients are hypocalcemic after their thyroidectomy, they're going to be receiving calcium replacements such as like IV calcium gluconate or calcium chloride. So overall, an easy way to remember sort of the important things of patients with thyroidectomy is this little acronym over here on the left is bow tie. All right, so high risk for bleeding. Make sure they have an open airway or patent airway. Whisper, because you don't want them using their voice too much. Also have a trach set at the bedside, just in case there's an emergency. They need an emergent tracheostomy placement. Watch their incision. So maintaining the neutral position of the head, semi-Fowler's position. You don't want to hyperextend the neck. And emergency, I kind of discussed already with like a high risk for bleeding, high risk for respiratory and airway compromise, etc. Real quick, here are the 2 differences between hypo and hyperthyroidism. Okay, I put some of the sort of like common signs and symptoms under each. But I would say that the 2 pictures of each that were earlier in the lecture would be something to go by for studying, okay? Also treatments. So hypothyroidism, you're going to replace their thyroid hormone with levothyroxine. Hyperthyroidism, you're going to give them anti-thyroid medications such as PTU, Tapazole, their potassium or sodium iodide. They may need some steroids, propranolol, and also surgical treatment, thyroidectomy. So nursing care. So monitoring for complications. Hypothyroid is going to be your myxedema coma. That's where everything sort of slows down, right? Nursing care for complications with hyperthyroidism is monitoring for the thyroid storm, which is an accelerated metabolism, okay? So to go further into nursing care for hypothyroidism, if they're on levothyroxine, you should be monitoring for overdose, which is your signs and symptoms of hyperthyroidism. All right. Also, how they should take their levothyroxine, which is empty stomach, right, with a full glass of water. Their diet is high protein, low calorie. And also remember that they are the patients you want to encourage fiber intake and fluid intake, and also frequent rest periods. For hyperthyroidism, nursing care to relieve symptoms and prevent complications. Calm environment. Remember, they're very nervous, excitable, sort of irritable, so you want to keep things calm for them, care for them in a very calm, unhurried manner. And then your post-op care for thyroidectomy, as mentioned on the previous page, especially paying attention to that acronym, the important things, bow tie. Thyroid disorders. So your parathyroid can also be hypo or hyper in terms of its secretion of parathyroid hormone, or PTH is sometimes what it's abbreviated as. So causes of hypoparathyroidism are what I just explained with the thyroidectomy page. So people can have a near total removal or a subtotal removal of the thyroid gland, resulting in removal of some of the parathyroid glands as well. So when patients have this, they tend to have low calcium levels, right? Because the parathyroid gland hormone helps to keep normal levels of calcium in the body. So if they've removed some of those, they're not going to be able to adequately keep up with the calcium. So their calcium level starts to drop. So they may have tetany, okay, which is that sort of major tonic spasm of the muscles. Chvostek sign, okay, I'll show this in class, and Trousseau sign as well. So the goal is to increase the calcium level to 9 to 10. That's your normal. So these patients will oftentimes be on calcium replacement, vitamin D, okay, because vitamin D helps to absorb calcium from the gut. So nursing care would include a calm, quiet environment, minimal stimulation, monitoring their cardiac status because of their risk for low calcium levels, recommend a high calcium, low phosphorus diet, because remember, calcium and phosphorus levels kind of have that seesaw effect. So if you have a low calcium level, you're going to have a high phosphorus level, and vice versa. So with patients who are hypoparathyroid, they have low calcium levels. So you want them to have, diets that are high in calcium and low in phosphorus. And then monitor for your signs and symptoms of hypocalcemia. So hypoparathyroid is rare, but it can be caused when there is either, like trauma or removal of the parathyroid glands with thyroidectomies. Then hyperparathyroidism. Okay, so this is basically an overproduction of the parathormone or parathyroid hormone. So when this happens, they have, an increased calcium level in the blood. So signs and symptoms would be muscle weakness. They'd have hypoactive DTRs, deep-tendon reflexes, nausea, vomiting, anorexic, constipation, hypertension, and risk for cardiac dysrhythmias as well. These patients may also be at risk for osteoporosis, because the parathyroid hormone actually stimulates bone resorption, which means that they're going to have low levels of calcium stored in the bones. Okay, so they have risk for osteoporosis, risk for fractures, etc. Also, patients with hypercalcemia or high levels of calcium could also be at risk for things like renal calculi, because sometimes like the kidney stones, renal calculi can be caused by calcium deposits. So treatment would be your parathyroidectomy, so removing the glands, and nursing care would be monitoring calcium levels, okay, monitoring for a hypercalcemic crisis, which means your calcium level's greater than 13. So that could be high mortality rate because of the risk for lethal dysrhythmias. Encourage PO fluid intake, avoid a diet high in calcium, and monitor for postoperative complications if they have a parathyroidectomy, which would be your signs and symptoms at that point of hypocalcemia, such as tetany. Okay? NCLEX practice number 1, we'll go through this in class. There's a couple of these. I'm just going to click through. And so that should be it. And I will also post a separate, very short lecture of Addison's and Cushing's.